Welcome to this explainer. Today, we're taking a deep, visual dive into the geography of the human chest, specifically mapping out thoracic incisions. We're really going to explore what you might call the ultimate surgeon's dilemma. Because on one hand, a thoracic surgeon needs absolute, critical access to the life-sustaining organs locked away inside the ribcage, the heart, the lungs, the great vessels. But on the other hand, they have a profound duty to ensure an optimal recovery, preserving the integrity and the appearance of the chest wall. So, how exactly do they strike that perfect balance? Well, let's map it out.
Here is our surgical roadmap for today. We're going to cover pre-op history and goals, the frontal approach, skin-sparing techniques, the lateral approach, extreme access with the clamshell, and finally, complications in post-op care.
Section 1. Pre-op history and goals. It's honestly wild to trace the history here. Humanity's attempt to access the chest cavity actually dates all the way back to ancient times, though back then it was mostly just for draining abscesses. The major architectural leaps, those happened much later. In 1897, Milton first described the median sternotomy for managing mediastinal tuberculosis. And then, jumping to 1909, we see Howard Lilienthal performing the very first modern thoracotomy. These early pioneers literally laid the groundwork for every single procedure we're discussing today.
Now, because we are dealing with arguably the most vital organs in the entire body, the prep is incredibly rigorous. To ensure absolute safety, every single patient goes through a strict clinical assessment long before they ever see a scalpel. We're talking detailed pulmonary function tests, spirometry to measure lung capacity, checking baseline oxygen saturation, and even initiating chest physiotherapy early on just to prepare those lungs for the sheer trauma of surgery. And this right here perfectly illustrates that core surgical dilemma we talked about, balancing the absolute non-negotiable need to adequately expose the area of interest against preserving chest wall function and appearance. To pull this off, surgeons actually navigate what are known as Langer's lines, those natural tension lines in the skin, to position their incisions in a way that maximizes cosmesis. Essentially, they want to leave the most visually acceptable scar possible.
Section 2. The frontal approach, specifically the median sternotomy. The reality of the median sternotomy is, well, it's intense. With the patient lying supine, an incision runs straight down the midline of the chest, starting up at the sternal notch at the base of the neck and going all the way down to the xiphoid process at the bottom of the breastbone. And then, an oscillating saw literally divides the sternum longitudinally. It's a breathtaking and incredibly aggressive maneuver.
So why go to such extreme lengths? It's all about that unparalleled direct access. Once the sternal retractor is in place and the ribs are parted, the surgeon has wide, highly symmetrical exposure to the central structures. We're talking the ascending aorta, the superior and inferior vena cava, the pulmonary artery, and all four chambers of the heart. For major life-saving procedures like coronary artery bypass grafting, complex valve surgeries, or a full heart transplant, this is absolutely the gold standard.
But, like everything in surgery, it's a massive trade-off. On the plus side, it's super quick to perform, exceptionally safe in terms of visibility, and surprisingly, it actually results in less incisional pain because the bone gets fixed so securely afterward. The drawbacks, however, are significant. It leaves a very poor cosmetic result, a large, prominent scar right down the center of the chest, and even more critically, it carries the very dangerous risk of an unstable sternum and mediastinitis, which is a deep, potentially life-threatening infection of the chest cavity.
Moving on to Section 3. Sparring the skin with mini sternotomies.
What if you don't need massive exposure and really want to spare the skin? Enter the brilliantly planned bikini-type inframammary incision. This perfectly demonstrates how modern surgeons navigate those natural Langer's lines. By hiding the cut right in the natural fold beneath the breast, they dramatically improve the cosmetic outcome for the patient, without completely sacrificing their access to the central chest.
Under the surface, a mini sternotomy often involves a J-shaped or partial split of the bone, requiring an incision of maybe just 4 to 6 centimeters. The whole guiding principle here is to preserve as much of that structural sternal framework as possible, while still being able to reach specific targets like the aortic or mitral valves. Now, this definitely reduces bodily trauma and blood loss, but make no mistake, working through a tiny window like that demands incredible precision and expert planning from the surgical team.
Section 4. The lateral approach, exploring thoracotomy incisions.
The naming conventions for these side incisions, lateral, anterolateral, posterolateral, can feel a bit like a complex geographical map, but geographically, they are all defined by their relationship to the latissimus dorsi muscle, which really acts as the major anatomical landmark on the lateral chest wall.
To actually achieve that specific anterolateral access, the physical mechanics in the operating room have to shift. Step 1, the patient starts in a supine position. Step 2, the chest is physically elevated at a 30 to 45 degree angle. And Step 3, the surgeon makes a curved, submammary incision that extends out laterally toward the mid-axillary line, carefully dividing the pectoral and serratus muscles to gain entry into the pleural space.
And the side of the chest totally dictates the game plan. The right anterior lateral approach allows for highly elegant, minimally invasive work on the mitral and tricuspid valves, meaning you completely avoid a full sternotomy. But on the flip side, the left anterior lateral approach is absolutely crucial for rapid emergency access. Since the heart sits slightly to the left, this is the go-to incision for severe trauma and resuscitative thoracotomies, where literally every single second counts.
What's really fascinating in modern surgery is the major push for muscle-sparing variants. Instead of aggressively cutting straight through those large muscles of the chest wall, surgeons have developed techniques to retract and spare the tissue, and the payoff is huge. Preserving that muscle results in significantly fewer postoperative complications and far less long-term pain for the patient.
Section 5. Extreme Access. The clamshell incision.
The clamshell is exactly what it sounds like. It's one of the most massive and extensive thoracic incisions imaginable. It is effectively a bilateral anterolateral thoracotomy that's connected straight across the anterior chest. The surgeon actually cuts through the 4th or 5th intercostal space on both the left and right sides, completely opening the entire chest cavity like a clamshell. It provides absolutely unparalleled exposure to everything at once, but, as you might guess, it's a highly traumatic, last resort measure.
Section 6. Complications and Care. Let's look at the post-op realities.
So we have to talk about the harsh timeline of complications. Early on, you're battling immediate threats: hemorrhage, a collapsed lung known as a pneumothorax, or blood pooling in the chest cavity. Later on, the threat shifts to terrifyingly severe infections, particularly osteomyelitis in the bone or mediastinitis in the chest cavity, which is heavily driven by Staphylococcus aureus bacteria, accounting for about 31% of cases. And just the physical positioning during surgery can cause painful brachial plexus nerve injuries in roughly 1 to 6% of patients. To manage these severe, very real risks, strict adherence to a pharmaceutical defense line is completely mandatory. This requires intraoperative pain management with IV pentazocine, ongoing epidural analgesia, a carefully managed mix of post-op opioids and NSAIDs, and a heavy reliance on prophylactic third-generation cephalosporins paired with metronidazole to aggressively ward off those life-threatening infections we just talked about.
And that brings our visual roadmap to a close today. We've seen exactly how thoracic surgery balances the extreme need for physical access with the very delicate realities of human recovery. But it leaves us with a pretty provocative thought, doesn't it? As robotic assistance and advanced muscle-sparing techniques just continue to evolve at breakneck speeds, what will the physical reality of chest surgery look like in the next century? Will these massive incisions just become a thing of the past? It's an absolutely fascinating medical journey, and definitely one to keep your eyes on. Thanks so much for joining me on this explainer, and I encourage you to keep exploring the incredible architecture of modern medicine.